Welcome to the Hospital Medicine Unplugged podcast.
Today we are undertaking a critical deep dive into anticoagulant management in hospitalized patients.
This is, I think, arguably the highest stakes balancing act we perform on a daily basis.
It really is.
You're trying to prevent these devastating thrombotic complications, VTE treatment, prophylaxis, stroke prevention, and A-flutter.
Right.
While at the same time, you're navigating this critical challenge of minimizing the bleeding risk.
That risk-benefit trade-off is absolutely central to what we do. And, we now operate with 4 major classes of anticoagulants.
We have the DOACs, low molecular weight heparin, or LMWH, unfractionated heparin, UFH, and then, of course, warfarin.
Exactly. And the modern complexity is really moving beyond just recognizing the contraindications. It's about mastering the nuances of individualized agent selection.
Especially when you're faced with complex comorbidities like acute kidney injury or, extremes of body weight. So our mission today is to provide you, the listener, with, let's call it a shortcut to being well-informed on the rational selection and the transition protocols for these agents.
And we're grounding this strictly in guideline-based care and, of course, the latest trial data.
Okay, so to make any rational clinical choice, we have to start with the foundation.
We do. The mechanism of action and the basic pharmacokinetics, the PK. These 2 elements really dictate who gets what and when.
So let's unpack the DOACs because they've completely revolutionized our practice. They really fall into 2 subcategories.
Right. You have the direct factor ZAZ inhibitors and then the direct thrombin inhibitor.
The ZAZ inhibitors, that's your rivaroxaban, apixaban, edoxaban, and betrixaban. They target factor ZAB, which is, a crucial part of the prothrombinase complex.
Effectively cutting the clotting cascade downstream.
And then you have the direct thrombin inhibitor, which is dabigatran.
What's truly transformative about the DOACs, though, is their highly predictable PK profile.
Oh, absolutely. Unlike warfarin, which is notoriously labile.
Exactly. DOACs achieve their peak therapeutic effect so reliably, usually within 2 to 3 hours of taking them orally.
And for the factor ZA inhibitors, that onset is really rapid, typically less than 4 hours.
Which makes them ideal for immediate initiation in, a lot of acute VTE settings.
So if we dive a little deeper into dabigatran, the original DOAC.
It's unique.
It is. It directly inhibits thrombin, or factor Ia, and critically, it inhibits both free and fibrin-bound thrombin.
That mechanism gives it a specific potency, but its PK profile is just dominated by its reliance on renal clearance.
A massive 80% is cleared by the kidneys.
It is. And that high renal dependence is exactly why dabigatran is often the first DOAC we pull the trigger on stopping when renal function starts to decline.
Right. And that kidney dependence, it varies among the factors I inhibitors, which is a huge factor in our dosing decisions.
It is. Rivaroxaban has about, 33% renal clearance?
Yeah, around there. Apixaban is much lower at about 27%, and edoxaban is up at 50%.
And that comparatively lower reliance for apixaban is why it retains a much wider therapeutic window.
And it's often the preferred agent in patients with, say, moderate but not yet severe kidney disease.
Right. We also have to be mindful of the initiation protocols. This is a point of frequent error in the acute hospital setting.
It really is.
Both rivaroxaban and apixaban can typically be started immediately without any parenteral lead-in.
Right, you just use those higher initial doses for the first 7 to 21 days before you step down.
But conversely, dabigatran and edoxaban still strictly require a 5-day lead-in with parenteral anticoagulation.
Almost always LMWH.
Almost always. It's to bridge that initial period until the oral agent can reach full efficacy.
Okay, so shifting to the heparins, let's start with LMWH, so agents like enoxaparin, dalteparin, tinzaparin.
These are indirect inhibitors. They work by binding to antithrombin, which then accelerates its ability to inhibit clotting factors.
And their primary action is anti-azexa, right? With a really skewed ratio of anti-azexa to anti-ASI activity.
Exactly. Usually about 3-to-1 or even 4-to-1.
The clinical advantage of LMWH over UFH is really its superior bioavailability, which you get via subcutaneous injection, and its longer half-life.
And that translates to a highly predictable weight-based dosing strategy that, for the most part, obviates the need for routine lab monitoring.
That predictability is what makes LMWH the outpatient standard. But,
similar to dabigatran, LMWH is predominantly cleared by the kidneys.
Which again makes renal impairment a critical limiting factor.
And then, of course, there's UFH, the original heparin. I'd argue it's the wild card in our arsenal.
That's a good way to put it. It's a heterogeneous mix of molecules that acts as an indirect inhibitor of multiple factors, ADIA, AX, IA, and X.
And it does this by accelerating antithrombin's action by up to 1,000-fold.
What makes UFH so clinically, I'll say, frustrating is its highly unpredictable PK.
That variability comes from its extensive nonspecific binding to plasma proteins and endothelial cells.
Right. It has biphasic elimination and a remarkably short half-life, only 60 to 90 minutes when you give it intravenously.
And while that unpredictability is a pain, its hepatic clearance, rather than renal clearance, is its saving grace in severe kidney failure.
It is, but that means you're stuck with frequent APTT or anti-Zaga monitoring to ensure efficacy and safety.
Finally, warfarin, the mechanism here is totally unique.
Vitamin K antagonism. It inhibits the synthesis of the vitamin K-dependent factors 2, 7, IX, X, and also protein C and S.
It's a broad-spectrum but very slow-acting anticoagulant.
And the crucial PK detail here, which often confuses people new to hospital medicine, is that the delayed onset, 36 to 72 hours, it's not a reflection of drug absorption.
No, not at all. It's strictly due to the time required to deplete the existing circulating clotting factors.
Factor 7 has the shortest half-life, about 6 hours, but the true onset of therapeutic anticoagulation is really determined by factor 2, prothrombin,
which has a half-life of 60 hours.
Exactly. So that extensive lag time means you must grid warfarin in almost all acute settings, and you need that constant INR monitoring.
It sounds like the Wild West compared to the predictability of the DOACs.
It really does.
But that broad, somewhat unpredictable mechanism is precisely what makes it the standard in some highly specific, challenging scenarios that we'll get into, where the DOACs have actually failed.
Okay, so understanding those PK profiles leads us directly to the clinical reality, the actual patient sitting in front of us.
Right.
When you're evaluating a new start or continuation of therapy, you have to recognize the standard of care.
Absolutely. For the vast majority of our patients who present with nonvalvular A-flutter or acute VTE, the DOACs have, and rightly so, earned their position as the preferred first-line agents.
And this is primarily because they offer efficacy that's comparable to warfarin, but with significantly lower major bleeding rates.
Most notably, that reduction in intracranial hemorrhage.
And when a parenteral agent is required, LMWH is generally preferred over UFH for both VTE treatment and prophylaxis.
And that's due to its superior efficacy, its safety profile, and just the convenience of that predictable weight-based dosing.
Okay, now let's talk about the critical modifiers, the things that force us to deviate from those preferred agents.
And nothing is more critical than organ function. So let's start with renal impairment. When the creatinine clearance, or CRCL, falls below 30 milliliters per minute, the playbook just changes dramatically.
It does. It pushes us right back toward UFH or warfarin.
UFH is preferred because its hepatic clearance completely bypasses those accumulation risks you see with renally cleared agents.
And in contrast, LMWH accumulation is a notorious problem in this population. Unadjusted therapeutic doses of enoxaparin, for example, have been shown to increase major bleeding risk by 2 to 3-fold.
That's a massive safety penalty. It's huge.
It's huge.
And this is why enoxaparin is the only LMWH with specific dose reduction guidance from the manufacturer that we have to follow, and we have to follow it strictly.
Right. For therapeutic dosing, when CRCL is less than 30, the dose has to be reduced by 50%.
Which means 1 milligram per kilogram once daily, rather than twice daily.
And for prophylaxis, we drop that dose to 30 milligrams once daily instead of 40.
But let me ask you this. How often in a busy practice are we truly monitoring the anti-SLO levels in those patients with a CRCL of, say, 20 to ensure we aren't dangerously under or overdosing them?
The reality is not often enough.
Right. And that just reinforces the complexity here.
That leads us directly to the DOACs and their renal cutoffs.
Dabigatran is contraindicated when CRCL falls below 30. That's a direct reflection of its 80% renal dependence.
And for the factor Zaga inhibitors, the contraindication threshold is generally below 15, though you often need dose adjustments in that 15 to 30 range.
But here's the fascinating sort of high-level nugget that really challenges the established dogma.
Okay.
The NCCN panel has acknowledged that there's limited, though it is observational, data supporting the safe use of apixaban in select patients with stage 4 chronic kidney disease, or even those on hemodialysis.
Which is strictly off-label.
Strictly off-label.
That is a critical piece of information. So when we encounter this off-label use, let's say a patient on dialysis who needs anticoagulation for aflutter and is just a poor candidate for warfarin. What does that intense scrutiny that's required actually look like in practice?
Right, because you can't just throw them on 2.5 milligrams twice daily and walk away.
No.
It means engaging in genuine shared decision-making with the patient. It means understanding the absolute limitations of the data we have and committing to specialized management.
Which often necessitates reliance on quantitative anti-Xia monitoring, even for prophylaxis.
Exactly, to ensure you're achieving some level of therapeutic drug concentration without risking accumulation. You are, for all intents and purposes, operating in the dark.
And you're relying on therapeutic drug monitoring protocols that aren't widely validated for that specific population.
But which help ensure the drug isn't completely cleared or, worse, catastrophically accumulating. And this is why UFH remains the safer default.
Okay, so shifting gears from renal status, let's talk about the complexity of the liver. Hepatic impairment also dictates our choice.
It does. And it often pushes us back toward warfarin in advanced liver disease, where DOAC PK becomes highly unpredictable.
Warfarin's mechanism, while it's complex, is at least understood in the context of synthesis derangement from liver failure.
In contrast, many DOACs are contraindicated in severe hepatic dysfunction.
Why is that?
It's because of the risk of unpredictable drug clearance. Many of them rely partially on hepatic metabolism and the patient's underlying coagulopathy from reduced clotting factor synthesis.
So, for instance, apixaban and rivaroxaban are contraindicated in child PU class B or C.
And dabigatran is specifically contraindicated in class C. Giving a DOAC in that setting is just a recipe for catastrophic bleeding due to overlapping risks.
Okay, so beyond organ function, we also have to adjust for extremes of body weight. For patients with morbid obesity, so a BMI of 40 or higher, there was this historical concern that DOACs might not penetrate or distribute enough to maintain efficacy.
That historical caution is increasingly being challenged. There's emerging evidence, including some recent meta-analyses, that support standard DOAC doses in this population.
And what does that show?
It shows not only comparable efficacy, but significantly lower risks of stroke and systemic embolism, a relative risk of 0.75 and lower major bleeding risk, with a relative risk of 0.74 compared to warfarin.
So our initial fears about efficacy were probably overstated.
It seems so, and the high PK variability and DDI burden of warfarin proved to be the greater risk.
But for LMWH, dosing in the morbidly obese is still fraught with complexity.
It is. Therapeutic LMWH dosing requires careful weight-based calculation and often needs anti-Xia monitoring to ensure adequate levels are achieved.
And specifically, the NCCN guides therapeutic enoxaparin dosing in patients with a BMI of 40 or higher to be 0.8 milligrams per kilogram every 12 hours.
Which is slightly less than the standard 1 milligram per kilogram. And if you don't monitor anti-Xia, you are essentially flying blind, risking therapeutic failure because of that massive volume of distribution.
Conversely, low body weight, so 60 kilograms or less, also requires adjustment.
This is where apixaban has a specific dose reduction requirement to 2.5 milligrams twice daily.
Right. And crucially, this reduction is indicated if the patient meets 2 of 3 specific criteria: age 80 or older, weight 60 kilograms or less, or a serum creatinine of 1.5 or greater.
And here's another surprising detail. Just like in the morbidly obese population, meta-analyses suggest DOACs actually have lower bleeding and thrombotic risks compared to warfarin in patients weighing 60 kilograms or less.
So avoiding the DOACs out of fear of low efficacy or high bleeding and extremes of weight might mean subjecting the patient to the known and higher risks associated with warfarin.
Precisely. The final assessment in this framework, though, must always be bleeding risk.
We rely on validated scores like HAS-BLED or IMPROVE, but clinically, a history of upper or lower GI bleeding is the most consistent and potent predictor of major bleeding on anticoagulation.
And when a high bleeding risk is identified, the literature helps guide our agent selection. Apixaban and the lower dose dabigatran, the 110 milligram dose, have repeatedly demonstrated the lowest major bleeding rates among all DOACs in aflutter populations.
Which makes them the default choices when we're prioritizing safety above all else.
Let's transition now from general patient factors to indication-specific protocols. Let's start with VTE treatment for the hemodynamically stable patient.
Okay. So for stable VTE, a DVT, or a non-massive PE DOACs, are the overwhelming first-line treatment.
They've proven non-inferior in efficacy to the conventional LMWH followed by warfarin regimen.
Right, and the Amplify-Y trial, which looked specifically at apixaban, showed non-inferiority for efficacy while offering a remarkable 69% lower rate of major bleeding.
A 69% lower major bleeding rate is a game changer.
It is.
And that safety margin is precisely why DOACs have largely superseded the need for LMWH bridging in this population.
But we have to ensure we are using the correct initiation protocol.
That's key. We mentioned that rivaroxaban and apixaban could be started immediately.
For example, rivaroxaban uses 15 milligrams twice daily for 21 days, and apixaban uses 10 milligrams twice daily for 7 days.
That initial higher loading dose is key. But for dabigatran and doxaban, that 5-day LMWH lead-in remains mandatory.
Because their initial PK profile doesn't provide that rapid, intense peak necessary for immediate VTE treatment.
Exactly. Unlike apixaban and rivaroxaban, it's a critical differentiation between the agents.
Next, let's move to cancer-associated thrombosis, or SECI. Historically, LMWH was the gold standard here.
It was, and that was largely based on the seminal CLA trial.
The CLA trial showed that dalteparin, when used for 6 months, reduced VTE recurrence by 52% compared to warfarin in cancer patients.
And that data dominated for years because of warfarin's complex PK in this population, which is just exacerbated by chemotherapy, poor nutritional intake, and unpredictable liver function.
But the guidelines have evolved so quickly. Now both DOACs and LMWH are considered Category 1 first-line options for SEC.
As long as the patient's CRCL is 30 or greater?
Right. And a network meta-analysis reinforces this, suggesting DOACs overall are highly effective.
With apixaban demonstrating the best net clinical benefit. Specifically, apixaban prevented 39 fewer VTE and major bleeding events per 1,000 patients compared to LMWH.
And if we look purely at efficacy, rivaroxaban actually showed the greatest VTE recurrence reduction,
with a compelling odds ratio of 0.49. But we have to address the critical caveat that so often dictates our choice in complex cancer patients.
which is.
LMWH remains preferred for patients with GI or GU tract lesions.
That is a major distinction. Why do the DOAC demonstrate this consistently increased bleeding risk, specifically at the GI and GU sites, compared to LMWH, which also causes bleeding?
It likely relates to the different absorption and clearance kinetics. LMWH is parenteral and metabolized differently.
Right?
The factor AG-DOACs, being oral, have direct high-concentration exposure to the GI tract mucosa during absorption.
I see. So in patients with active lesions, be they primary tumors, metastases, or related complications.
Exactly. This localized high concentration of the drug acts as a severe irritant or an accelerator of existing microbleeding that LMWH just bypasses.
And this is such a strong signal that it completely overrides the overall superior safety profile of the DOACs in this specific anatomical context.
It does. It's a crucial insight for clinicians managing TOG.
Okay, now for the non-negotiables, the absolute warfarin indications where DOACs are completely contraindicated.
Well, this is a short, firm list.
Mechanical heart valves, rheumatic valvular aflutter, and triple-positive antiphospholipid syndrome.
And the mechanical valve contraindication for DOACs is absolute and cannot be overstated.
The clinical trials were terminated early in this population, specifically for dabigatran.
Due to alarming rates of increased thrombotic and bleeding complications compared to warfarin, it is a major safety pitfall to mistakenly switch a patient with a mechanical valve to a DOAC.
So warfarin, despite its difficulties, controls these high-risk clotting surfaces better.
It does. And finally, pregnancy.
LMWH is the agent of choice for VTE treatment or prophylaxis during pregnancy.
Right. Warfarin is teratogenic in the first trimester. It causes embryopathy,
And DOACs cross the placenta and their fetal safety is unknown.
which leads to the absolute contraindication of both warfarin and DOACs during pregnancy and breastfeeding.
Moving from therapeutic treatment to VTE prophylaxis within the hospital setting.
Here, LMWH, typically enoxaparin or dalteparin, is the preferred first-line choice for most medical and surgical patients.
And clinical trials have shown that intermediate-dose LMWH regimens offer the best balance of benefits and harms in high-risk medical populations.
This leaves UFH reserved for two distinct scenarios.
First, patients with severe renal impairment, where that LMWH accumulation risk is just too high, so a CRCL less than 30.
And UFH's hepatic clearance is the advantage there.
And second, patients who may need rapid reversal capability.
Like those with very high bleeding risk or those undergoing an anticipated invasive procedure where you need quick cessation.
It's vital to clarify the approved role of DOACs here.
It is. Rivaroxaban and betrixaban are FDA approved, but not for routine inpatient prophylaxis initiation.
No, they're approved specifically for extended prophylaxis, meaning after discharge in high-risk, acutely ill medical patients.
And that's based on trials like Mariner and Apex. They aren't intended for the typical 2 to 5 day inpatient prophylaxis stay.
Right. And warfarin, due to its delayed onset and intensive monitoring needs, is never used for acute VTE prophylaxis.
Okay, next let's address acute coronary syndromes, or ACS.
When you're managing acute events, the landscape shifts entirely toward agents that offer fast onset and rapid reversibility.
And UFH is the standard anticoagulant for PCI in ACS protocols. It holds a Class 1 recommendation.
The preference for UFH is purely pragmatic, right? It's driven by its short half-life and its complete, immediate reversibility with protamine sulfate.
Exactly. When a patient is going emergently to the cath lab for rapid revascularization, UFH gives the team the control they need to turn off anticoagulation instantly if complications arise.
LMWH, specifically enoxaparin, acts as a recommended alternative for NSTE ACS.
Particularly when an early invasive approach is not anticipated.
Right. The ESSENCE trial demonstrated that enoxaparin reduced the composite risk of death, MI, or recurrent angina compared to UFH in this subgroup.
But, and we have to reemphasize this, the mandatory dose reduction is critical. 1 milligram per kilogram once daily if the patient has a CRCL less than 30.
Right. And neither warfarin nor DOACs are appropriate first-line agents for acute ACS management.
Their role is purely long-term, managing chronic A-flutter or treating a left ventricular thrombus.
And if a patient with A-flutter needs to undergo PCI, the modern standard has shifted.
It has. DOAC-based dual antithrombotic therapy is now strongly preferred over the historically complex warfarin-based triple therapy.
Due to drastically lower bleeding rates.
Moving to monitoring, one of the biggest conveniences of DOACs is precisely their predictable PK.
Which means they generally require no routine monitoring.
And that is a massive improvement in patient management. But when are the exceptions?
The exceptions are critical because they represent high-risk situations.
Quantitative assessment becomes necessary in the face of active bleeding, suspected overdose, acute kidney injury, or extremes of weight.
Basically, anywhere we suspect their predictable PK might be failing.
Right. And when we do need a specific level, we have to rely on specialized assays.
So for dabigatran, we use a dilute thrombin time, or TT, or acurin-based assays.
And for the factor ZAZ inhibitors, we must use calibrated anti-assay assays with drug-specific calibrators. You cannot rely on a standard anti-assay assay calibrated for LMWH.
Okay, and here is the absolute clinical correlation that often saves lives in the emergency setting.
A normal TT effectively excludes clinically relevant dabigatran levels.
However, and this is a common pitfall, normal PT, APTT results do not exclude clinically relevant levels of factor Z inhibitors like apixaban or rivaroxaban.
That's such an important point. If you have a bleeding patient on apixaban with a normal PT, APTT, you cannot assume the drug is gone.
That patient is still significantly anticoagulated.
For LMWH, routine monitoring is also typically unnecessary. However,
anti-ASI levels are reserved for the populations where PK variability creeps in.
Pregnancy, extreme obesity, or when CRCL is less than 30.
And the target peak range for twice-daily VTE treatment is usually 0.6 to 1.0 units per milliliter, measured 4 hours post-dose.
UFH, conversely, always requires monitoring, historically with the PT, APTT.
But we are seeing a major trend toward anti-Zyza monitoring for UFH.
Targeting 0.3 to 0.7 IU per milliliter. This is particularly relevant in the critically ill or in patients with acute inflammatory states.
Like severe sepsis or COVID-19.
Exactly, where inflammation and coagulopathy can confound the PTT, APTT results, giving you a misleadingly high or low number. Anti-Zygas monitoring bypasses that inflammatory interference.
And then there's warfarin, where the INR target is 2 to 3 for most indications.
The primary safety principle here is recognizing that an INR greater than 4 provides absolutely no additional clinical benefit, but substantially and rapidly increases the bleeding risk.
And warfarin monitoring is so heavily impacted by dietary vitamin K intake and its extensive hepatic metabolism via CYP2C9 and 3A4 pathways.
It makes it a lightning rod for drug interactions.
Which brings us directly to drug safety pitfalls, starting with drug-drug interactions or DDIs.
This is crucial for warfarin, but it's equally so for the factor ZACA DOACs, which are substrates of CYP3A4 and P-glycoprotein.
So strong CYP3A4 inhibitors, like the azole antifungals, will significantly slow the metabolism of the DOACs,
which spikes their plasma levels and causes a dangerous bleeding risk.
And conversely, strong inducers, like phenytoin or carbamazepine, dramatically accelerate the metabolism,
decreasing DOAC levels, which risks devastating thrombotic events.
We should note that edoxaban demonstrates fewer clinically significant DDIs than rivaroxaban and apixaban,
which gives it a relative safety advantage in polypharmacy patients.
And finally, the critical safety alarm, heparin-induced thrombocytopenia, or HIT.
The risk is significantly higher with UFH than LMWH, but if HIT is suspected, and that's typically indicated by a 4T score of 4 or greater,
you must stop all heparin immediately.
Both UFH and LMWH. That feeling of stopping all heparin immediately when the 4T score comes back high, that is a high-stakes, stressful moment.
It is a non-negotiable, time-sensitive, life-saving decision, and management requires initiating alternative parenteral agents.
Argatroban, bivalirudin, or fondaparinux while you're awaiting definitive diagnostic results.
You cannot wait for the platelet factor 4 antibody test to come back before acting.
When life-threatening bleeding occurs, knowing the specific reversal strategy is paramount. For the direct thrombin inhibitor, dabigatran, edarucizumab is the recommended first-line agent.
Edarucizumab is administered as a 5-gram intravenous bolus, and it provides complete 100% reversal within minutes. It's a highly effective, targeted agent.
For the factor A's inhibitors, so apixaban and rivaroxaban, we have two primary options.
And dexanet alpha is the specific reversal agent.
Its dosing is complex. It depends on the specific DOAC, the dose, and the time since the last administration. 4-factor PCC is an equally recommended alternative,
especially when annexanet alpha is unavailable or the cost is prohibitive.
The recent NXAI trial provides a critical safety paradox that we really have to internalize.
What did it show?
Well, andexanet alpha showed superior hemostatic efficacy compared to usual care, which was predominantly 4-factor PCC.
It was associated with a significantly increased risk of thrombotic events, including ischemic stroke.
So this means we are effectively trading immediate, better bleeding control for a higher short-term risk of a new clot.
That is the ultimate clinical pension. If you have an acute intracranial hemorrhage, your priority is to stop the bleed now.
But knowing that the tool you're using carries a higher risk of causing a devastating ischemic stroke immediately afterward, it creates an agonizing decision tree.
It forces us to have an extremely detailed conversation with surgical and neurological teams about whether that superior hemostatic efficacy is worth that specific thrombotic risk profile.
For unfractionated heparin, we have the benefit of complete 100% reversal with protamine sulfate.
The standard dose is 1 milligram of protamine per 100 units of heparin.
But this has to be adjusted based on the time elapsed since the last UFH dose, and it must be administered slowly over 10 minutes to mitigate risks of hypotension, bradycardia, and anaphylaxis.
And for LMWH, the reversal is only partial.
Due to its different molecular size and binding characteristics, we can expect to neutralize only about 60% of anti-ZEXA activity with protamine sulfate.
And dosing is also time-dependent. Typically 1 milligram of protamine per 1 milligram of enoxaparin if it's given within 8 hours of the last dose.
But that amount is reduced if more time has passed.
For warfarin-associated life-threatening bleeding, the standard is 4-factor PCC plus intravenous vitamin K.
The PCC provides immediate factor repletion, correcting the INR within minutes.
And the vitamin K is essential to restore endogenous factor synthesis, but its onset is delayed 4 to 6 hours intravenously,
which makes the PCC necessary for that immediate stabilization. Fresh frozen plasma, or FFP, is now a secondary alternative.
Because it requires massive volumes and carries a higher risk of volume overload, especially in our cardiorenal patients.
So let's conclude with perioperative management and transition protocols, which are just central to hospital medicine.
For planned procedures, time reversal, or simply holding the drug, is always the preferred and safest strategy over pharmacologic reversal.
And the pause protocol gives us a validated, evidence-based roadmap for DOAC interruption.
For low bleeding risk procedures, we hold the DOAC for 1 day. For high bleeding risk procedures, we hold it for 2 days.
Assuming normal renal function. If renal function is impaired, especially for dabigatran, the hold time can extend up to 4 days for high-risk procedures.
And it prevents that unnecessary LMWH bridging.
Speaking of bridging, we need to hammer home the finding of the BRIDGE trial.
which demonstrated that routine bridging with LMWH for warfarin interruption is generally not beneficial for patients with A-flutter.
And it actually significantly increases the major bleeding risk without reducing thromboembolism.
So bridging should be reserved only for truly high-risk patients.
Those with mechanical mitral valves, cage ball or tilting disc aortic valves, or a VTE that occurred within the previous 3 months.
Anyone else on warfarin who is at high bleeding risk gets no bridging.
And when you're switching a patient from a DOAC to warfarin upon discharge, we must overlap the agents until the INR is therapeutic.
Meaning 2.0 or greater for 2 consecutive days.
Which takes at least 4 to 5 days, given that warfarin PK lag.
Finally, let's just revisit VTE initiation. Retrospective data suggests that even for the DOACs that don't technically require a lead-in, like rivaroxaban or apixaban,
Right.
providing an initial 3 to 5 days of LMWH lead-in may provide optimal short-term outcomes, including reduced mortality.
Particularly in high-risk acute PE patients, compared to starting the DOAC immediately. This remains a topic of clinical debate and often comes down to institutional practice.
This deep dive really reinforces that anticoagulant choice is a highly personalized algorithm.
It is. You're balancing PK, clinical indication, and patient risk factors.
Yeah.
I think we've established 3 central factors that guide our decisions.
First, creatinine clearance, where UFH becomes the agent of choice for severe impairment.
Second, the indication where warfarin is just non-negotiable for mechanical valves.
And third, bleeding risk, where apixaban often demonstrates the most favorable profile.
And we have to integrate the specifics of the trial data amplify why, showing apixaban's superior safety, CLOT supporting LMWH and CA, which has now been largely superseded by DOACs.
And pause, guiding our perioperative decisions. We urge you to take this detailed framework and apply it to your complex admissions and discharges this week.
Moving beyond the checklist and into true individualized care.
To conclude, let's reflect one last time on that complex reversal strategy.
We know that for patients experiencing an intracranial hemorrhage while on factor area inhibitors, the reversal agent andexanet alpha achieves better immediate hemostatic efficacy than 4-factor PCC.
But as we discussed, that superior hemostatic efficacy comes with the significant cost of an increased rate of thrombotic events, specifically ischemic stroke.
And this raises an important ethical question for us as clinicians operating in the acute care setting.
How should we weigh the acute, often existential need for superior bleeding control against a higher short-term risk of ischemic stroke when choosing a reversal agent for an acute intracranial catastrophe?
It demands ongoing vigilance and individualized patient counseling every single time we face that decision. Thank you for joining us for this deep dive.